are no more questions for this portion of the presentation, we do have a few announcements from our president, and I will turn it over to her.
Hi everyone again. Just have a few announcements for us here. Um, First, that BAMPA is has several opportunities for new members, and so membership is free for PA students and pre-PAs. There is a small fee for PAs as well as other medical providers or professionals that are willing to join us. We do have an October newsletter that's going to be going out to the members very soon, including a survey for a mixer where we're going to be getting your ideas for to see what we can do to kind of help us evolve into a social gathering. So we'd like your input on that. Also coming up soon is a pharmaceutical sponsored dinner in November, again to engage our PA members. And so that's something to look forward to. Thank you.
Thank you so much, President Ilogo. All right, and we have with us our next speaker, Dr. Ikechukwu Mbonu, is a rheumatologist at Sentara Rheumatology. Dr. Mbonu is devoted to the diagnosis and treatment of all types of musculoskeletal conditions affecting joints, muscles, and bones. Some conditions that he treats are inflammatory arthritis, connective tissue disease, and osteoporosis. Dr. Mbonu's clinical interests include systemic lupus erythematosus, rheumatoid arthritis, health disparities, and health equity. When he's not caring for his parents, Dr. Mbonu enjoys playing soccer, traveling, and dancing. Please extend your attention to Dr. Mbonu as he presents manifestations of lupus.
Thank you very much for that presentation. Can you guys hear me well?
We can, yes.
Okay, good. I'm very happy to be here. Let me try and share my screen and see how that works. Can you all see my slideshow?
Yes.
Great. Well, my name is Dr. Ikechukwu Mbonu, and most people call me Dr. Ike because that's what they remember. I'm very privileged and very honored to be presenting this talk to you guys. I'm going to assume that most of the audience has either seen a patient with lupus, treated a patient with lupus, or will see a patient with lupus. It's one of those rare diseases that is not so rare, especially if you're in clinical practice. I know there's questions at the end, but feel free to just interrupt me if you have any questions or anything doesn't match up. So if there are no objections, I'll go ahead and get started. Is that okay?
That's great.
That's great.
Good. All right. So I have no disclosures. It's something providers commonly do. I don't have any disclosures for now. So I'm just going to go ahead. Now, wild guess as to what all these people have in common. Well, given the title of the topic, it's not a big leap to suggest lupus. These well-known celebrities all have lupus, one version of lupus or another, which, by itself is very informative in that lupus itself, the disease, has kind of one name, but it has very many faces. It has very many manifestations, and it can technically affect anyone, and it can look very, very differently. So these are some of the celebrities we know who have opened up about their diagnosis of lupus, and they're all still with us. And I think most of them are doing very well. So what exactly is lupus? Because like I said, the name lupus is very generic and it means a lot of things to a lot of people. But essentially, lupus is a chronic autoimmune disease that causes inflammation throughout most tissues in the body, systemic inflammation. So that's crucial. That's the underlying pathophysiology without getting too deep into it of what's going on in lupus. Like I alluded to before, it's very heterogeneous. So it can appear in a multitude of ways. Some patients have predominantly skin issues, some have joint issues, some have all of that. It can also have organ-threatening manifestations such as nephritis or diffuse alveolar hemorrhage in the lungs. So some people have even suggested that lupus is not one disease. It's probably a group of diseases that we just call the same thing. But it kind of gives you a flavor of the complexity of the disease. So this essentially is a definition. So the epidemiology, this is always important when trying to describe a quote unquote rare disease. But like I said, it's rare, but not that rare. About anywhere between 20 to 150 cases per 100,000 of people per 100,000 people in the United States will have a diagnosis of lupus, depending on what studies you're looking at. This, as with most autoimmune diseases, this is increasingly more likely to happen in women. And prevalence rates vary from 164 per 100,000 in white individuals to 406 per 100,000 in Black females or females of African American descent. Geography and race appear to have an effect on the prevalence of lupus and the frequency and severity of the disease manifestations. So we find that in the disease appears to be more common and sometimes more severe in urban areas compared to rural areas. And in the United States, as with most of the world, well, in the United States for sure, there's a higher prevalence amongst African American, African Caribbean, Hispanic, and Asian women compared to white women, or white people of white descent. Now, I had mentioned this can affect anybody, but the common demographic is young African American female with lupus. Is who gets diagnosed with lupus. Now, speaking of diagnosis, the age of onset also varies. Like I said, typically it's young African American or young Hispanic female who gets diagnosed with lupus, but it doesn't have to be that. This chart shows the age of onset compared to other well-known autoimmune diseases. We can see, as you can see with lupus at the bottom, age of onset begins around age 15, going all the way to 45. But as an adult practitioner, I've diagnosed some patients in their 60s and 70s with lupus. Tends to be less severe the older the patient is, the older the age of diagnosis. But generally, you can see there's a big range of diagnosis in comparison to other things. Type 1 diabetes is a younger patient. Multiple sclerosis kind of mimics lupus in terms of age of diagnosis or age of onset, I should say. Whereas RA has a more broader range compared to other autoimmune disease. So that's just something to keep in mind. Now, lupus, again, speaking to the complexity of lupus, there are different kinds of lupus, technically speaking. You have the cutaneous lupus, you have the systemic lupus, you have neonatal lupus, and you have drug-induced lupus. Now, these subsets of lupus are the most common types of lupus you will find in textbook. But depending on the textbook you're looking at, depending on the speaker who's talking, you might find even more varied types of lupus or definitions of lupus. For instance, some people don't consider neonatal lupus at all. Drug-induced lupus is not as common, but it does exist. But today we'll be spending most of our time really, when we talk about lupus going forward, we're really talking about systemic lupus. That is the lupus we'll be referring to, spending most of our time on. Now, cutaneous lupus is pretty common. Well, that's lupus that's just limited to the skin, and you have different versions of that. You have the subacute cutaneous lupus and you have the discoid lupus. So over here in this first picture, what you're seeing is the classic malar rash, also known as butterfly rash. Now, this is kind of what lupus is known for. Fun fact is that when the disease was first described, comes from a Latin word meaning wolf. So they looked at this as kind of appearing to be a wolf bite. I've never seen a wolf bite victim before, but apparently this is what it would look like. So that's kind of how it got his name. And here's the famous singer, R&B singer from the 90s, Seal. He has what looks to be discoid lupus. And then another picture here is the same kind of rash in an African American person. Now, one of the things about lupus is that, if you recall, I mentioned in the United States, predominantly affects African Americans compared to other subsets. But the textbooks are filled with, and my slides included, are filled with descriptions of lupus on white people. And that has also kind of had a bias in terms of diagnosis, because med students and doctors and everyone tend to be taught lupus based on images of white people. And when these manifestations occur in African Americans, they're less recognizable because people have not been taught that. So it's also harder to find images of Black people with skin lupus, just because it's out there. The publications tend to be white Caucasian images. Now, drug-induced lupus, I'll touch on it very briefly. So we use a lot of these. Well, some of these drugs we don't use anymore, but these are the drugs that are typically implicated in drug-induced lupus. The list is a lot longer, but these ones are, if you come across a patient who has symptoms suspicious for lupus, you want to look through their med list and see if they're on any one of these prescriptions. Obviously, based on this, the highest prevalence will be drugs like procainamide and hydralazine. Hydralazine we still use a lot. Procainamide, but they tend to be culpable in drug-induced lupus. And drug-induced lupus, on a whole, tends to be not as severe as systemic lupus. And once you stop these drugs, the symptoms they have, which is usually skin rashes, photosensitivity, sometimes pleuritis, goes away after a while. But it's also it's key to look at the drug list of the patients you see. As rheumatologists, we use anti-TNF agents a lot. So something we have to watch out for. Minocycline, it's used quite, and isoniazid, it's still commonly used, but it's something we want to keep an eye out for. So I'm going to touch on the various clinical manifestations of lupus, but first off at the constitutional symptoms. These don't really fit into any one system, but these are fairly common and then are usually seen at diagnosis or the onset of this disease. Fatigue is very common. Almost all patients with lupus, active lupus, will have some fatigue. And if you've ever seen a patient who has lupus, or indeed fatigue, it can be quite disabling. So, and when you talk to patients, you find that the onset of fatigue was quite dramatic. It's usually quite, they can tell you when they start feeling really bad. Fever is another symptom, another constitutional symptom that you will find in about half of patients with active disease at the onset. So it's always important to ask the patient about fever. Not every fever is an infection. Myalgia, which is soreness of the muscle, is also fairly common amongst lupus patients. They tend not to have severe muscle weakness or myositis. Myositis is the inflammation of the muscle, whereas myalgia is just the achiness of the muscle. And that tends to go hand in hand with fatigue. Weight change is also something you should watch out for. There's usually unintentional weight loss at the onset of symptoms. And if you note, these constitutional symptoms are also fit pretty well for cancer. So something you should also watch out for. But the age will kind of, cancer is usually diagnosed in patients in their 60s, 70s. Lupus tends to be diagnosed in younger patients. But still, it's something you kind of want to keep your antennas up for. Also, the weight change could be weight gain or weight loss. Weight loss typically at the onset of the disease. Weight gain tends to be with um, either side effect or response to treatment, particularly corticosteroids. Now, the cutaneous manifestations. Now, the cutaneous, like I had mentioned earlier, there are patients with only cutaneous lupus. All they have is just the skin manifestation of lupus. And that tends to be, cutaneous lupus tends to be made via skin biopsy because usually their serologies, their lab work are usually negative sometimes, most times, and they have these skin lesions that turn out to be cutaneous lupus. But many patients with systemic lupus will have skin manifestations of lupus, and there's a lot that I will touch on later. So here you see again is that classic malar rash, butterfly rash. It goes across the nose to the cheeks, and this can be confused with a lot of things. There are a lot of rashes that can look like this, but this is the classic butterfly rash. You usually see this when the patient is having a flare-up. It tends to be photosensitive, that is in reaction to being in the sunlight. And how you really differentiate it from other facial rashes is that it spares the nasolabial fold. So that in lupus patients, that this part of the lip or the face tends to be spared. Now, rosacea can look a lot like this and can be confusing. So you kind of want to pay attention to the other symptoms the patient is having, look and see if the nasolabial folds are spared. And another clinical pearl that I've noticed is with rosacea, when you touch it, it blanches. That is the part where you put your finger on, it kind of, the redness disappears. And when you let it go, the redness comes back. And that's a sign that that's rosacea and not a lupus rash. So this is acute lupus rash. So this will be acute cutaneous lupus erythematosus. Up here, what you see is discoid lupus. Now this is chronic cutaneous lupus erythematosus, or otherwise known as discoid lupus. Now this is a scarring kind of rash. It's healed over, and the scars will remain kind of forever, really. And patients with discoid lupus tend to just have discoid lupus, like I had mentioned earlier. But that is part of one of the rashes that can be seen in chronic cutaneous lupus. You have other rashes like timidus profundus. Profundus is like inflammation of the subcutaneous fat, and then Chilblain's lupus, which is kind of a reddening of the toes and fingertips, usually in response to stress, cold weather. It tends to be associated with pain at times. There is a picture of this I will show you. And then subcutaneous lupus is kind of another skin rash you see in patients who are having a lupus flare. It's not quite chronic, but it's also not the malar rash. We'll go to the next slide here. So this is an example. These are examples, I should say, of subacute cutaneous lupus. Now, this rash tends to be very photosensitive. In other words, it's a response to being out in the sunlight. It affects sun-exposed areas such as the upper neck, upper back, the forearms, or the back and the shoulder. And patients who have these rashes tend to always have the SSA or Ro antibodies. Most of them tend to. This is one of the reasons we advise patients with lupus to stay out of the sunlight if they can, or at least not be in the sunlight for prolonged periods, because it can, in some patients, it can trigger a flare-up. So yeah, this is what, and as you can probably tell, this rash is easier to pick out on Caucasian patients, but it would be a lot difficult to pick this out on African American patients. Now, there's other skin manifestations of lupus. They include Raynaud's phenomenon, which is kind of skin/vascular phenomenon. I'll share a picture of that later. You can have mucosal ulcerations. That is, lupus patients tend to have ulcers in their mouth or their nose. Most of their ulcers tend to be painless. Sometimes it could be painful, usually on the upper palate, sometimes on the buccal mucosa. But you kind of have to be looking for this to find this. Sometimes the patients will tell you, but usually you have to ask them and you have to go searching for it. And then photosensitivity, like we described, what I had alluded to earlier, is a big feature actually of lupus. Uh, and photosensitivity, working in clinical practice, a lot of patients will tell you, "Oh, I'm photosensitive. I don't like being out in the sun. I burn very easily." That is not photosensitivity. Photosensitivity in lupus is patients tend to feel sick after being out in the sun. They kind of get nausea. There's this feeling of being sick. They get rashes that develop like an hour after being out in the sun. You can sometimes get headaches. That's real photosensitivity. Burning easily is really not photosensitivity, and like your eyes burning or just not feeling very hot is not really photosensitivity. And then alopecia is another skin manifestation of lupus. This could be due to discoid lupus or acute lupus. Alopecia tends to be patchy. Um, and again, from my experience, this can sometimes be hard to diagnose in African American patients because of their hairstyle. So a lot of patients who are not quite diagnosed with lupus, who have some symptoms, and you examine them and they have alopecia, which can sometimes be at the sides of the temples. The patients tend to chalk it up to the weave or the hairstyles or the braids. Oh, my hair pulls a lot. My hairdresser has been pulling on my hair a lot. Has been chipping, but really it's lupus. Sometimes lupus. Then livedo reticularis is a lace-like rash that can be seen in lupus patients, mostly in lupus patients who have antiphospholipid syndrome. I'll talk about that a little bit later. And then hives and urticaria, believe it or not, is a feature or manifestation of lupus. Hives and urticaria we associate with allergic reaction, but that can sometimes be the first manifestation of lupus. So you have to keep an eye out for that, or don't disregard it as though the patient just had an allergy. Oftentimes, when they have hives and urticaria, you can't really pinpoint what they were allergic to. So these are some skin manifestations. This is an example of the livedo reticularis I was talking about earlier. You see this usually around the lower extremities or across the knees. Tends to be in antiphospholipid syndrome, but lupus patients can have this rash. Here you have Raynaud's phenomenon. This is a very dramatic picture of what Raynaud's looks like in the hands and the feet. The Raynaud's tends to be, again, exposure to cold weather, stress. Patients, you ask them when you go to the grocery store, the freezer aisle, does this happen? And they'll tell you yes. Um, so it's not specific to lupus because you can find Raynaud's in other diseases, other connective tissue diseases. You can also find it in patients who don't have any disease. It could just be primary Raynaud's. What's really going on here is a spasm of the blood vessels. And here you see discoid lupus. This is the alopecia I was referring to. This patchy alopecia is very pathogenomic of lupus. This is likely discoid lupus, and here you can see active lupus. When it's acute lupus, it tends to grow back. It tends to come back. But with discoid lupus, it's gonna be pretty much like this. And here, these two pictures, although it looks like Raynaud's, it's actually Chilblains. This is one of those um, examples of chronic lupus as Chilblains, fingertips with redness. Tends to be very painful. A response to aspirin and gabapentin. So the musculoskeletal manifestations are huge in lupus. Most lupus patients will at some point have arthalgias and arthritis. Arthalgias being the sensation of pain in the joints, whereas arthritis is actually inflammation of the joints with swelling and redness noted in the joints. So most patients will have it. Usually is symmetrical, left and right hand, left and right feet. It kind of appears like rheumatoid arthritis. The only difference is that in lupus, the arthritis is non-erosive, whereas in rheumatoid arthritis, it is erosive, meaning that the inflammation can actually chip the bone, damage the bone. With lupus, it usually doesn't. But lupus patients can have what we call Jacuzza arthropathy, which is what you see here. This is kind of re you can straighten out their fingers, but once you let it go, it goes back to this form, and this is what we call Jacuzza arthropathy. This is just the ligaments holding the joints together have been damaged. They can have myalgias and myositis. We discussed the myalgias earlier. That feeling of just muscle aching. Myositis is actually an inflammation of the muscle. It happens in lupus. It's quite rare, but it can happen. There's elevated muscle enzymes, CPK is up, LFTs are up. There's weakness, but usually most lupus patients tend to have myalgias. Then avascular necrosis. This is kind of a serious complication of lupus. This is where there's compromise of the blood vessels in the blood, causing collapse of parts of the bone. You tend to see this in younger females, teenagers, or patients who have been on long-term steroid use. So this is not always an apparent diagnosis. You kind of have to have the index of suspicion to go looking for this. But it can present like joint pain, usually hips. Patient is having hip pain after their lupus appears stable. You kind of have to go searching for this. And then osteopenia and osteoporosis is also a complication of long-term lupus. Um, the osteoporosis typically happens around 60s and 70s for most women. But patients with lupus kind of get it earlier, just the thinning of the bone. And generally, most patients with lupus have been on steroids, so that also accelerates this process. So here you have an MRI image of avascular necrosis, also called osteonecrosis. So this is kind of been highlighted for us. You can compare the two, the femur, and you see this is well vascularized. This is not so much. The surgeons tend to go in and put a pin in it, and this has to be stabilized. It requires surgical treatment. They generally go in and put a pin in it. Um, and you want to, unfortunately, most people who have this kind of need to be on long-term steroids because of their disease anyways, but you want to minimize that as much as possible. So this is lupus on its own can do this de novo, but steroids tend to be implicated in this. So I want to talk about fibromyalgia and lupus because most of you probably have heard of fibromyalgia or know about fibromyalgia or have seen patients with fibromyalgia or may indeed have fibromyalgia. Fibromyalgia is not an inflammatory condition. It's a chronic pain central nervous system disorder that causes widespread pain, and it can mimic lupus. The symptoms, there's a lot of symptoms that overlap between both of them. So it's kind of important to distinguish the two. And lupus patients tend to have fibromyalgia in higher frequency than non-lupus patients. So this can be a big red herring, something you have to watch out for. So right here, I've outlined some of the common features of fibromyalgia. They have widespread pain, they have a lot of fatigue, they have brain fog, sleep issues, headaches. They tend to have IBS. They almost always tend to have neuropathy, numbness, tingling, can be anywhere, upper, lower extremity, sometimes on the face, sometimes on the chest. They're very sensitive to pain. The patients will tell you, hugging me is very, very, uncomfortable. Certain points tend to be tender. But back in the day, they used to have to measure tender points to come up with a diagnosis of fibromyalgia. We don't do that anymore, but this is a common feature of fibromyalgia. Depression, anxiety, overactive or irritable bladder, and pelvic pain. So, fibromyalgia patients will have 3, 4 of this, but the ones I highlighted, you can see them in lupus. Widespread pain, we see that in lupus patients. Fatigue, brain fog, sleep disturbances. These are also features of lupus. So you kind of have to be aware which is which because the treatment is very different. Like I said, there's actual inflammation going on causing these issues. Fibromyalgia is not inflammatory. It's not damaging and doesn't require the same medications. So This can be very confusing. It can be very tricky. So try to, um, as a primary care physician, you want to provide it. You want to try and make that distinction. Obviously, labs help. Lupus can also affect the lungs. Most patients with lupus lungs or with manifestations in the lung, it tends to be pleurisy. This is where the patient has pain with breathing. Breathing tends to be difficult because when they inspire and expire, there's some pain around the chest. That tends to be the most common manifestation. But they can also have acute lupus pneumonitis, which is like an allergic reactions within the lung. It can look like pneumonia as well. So a lot of these can actually look like pneumonia. So you kind of have to be careful to tease out the information, the onset, the other features. Labs and imaging obviously help. They can also have interstitial lung disease. This needs to be managed by a pulmonologist and a rheumatologist. But this is actual inflammation, chronic inflammation in the lungs that damages the parenchyma of the lungs, and it could lead to bad outcomes. Lupus patients tend to get PE, pulmonary embolism, at a higher rate than the regular population. They can also have pulmonary hypertension. This is one of the causes of pulmonary hypertension. And kind of unique to lupus is this condition called shrinking lung syndrome. This is a situation wherein the lung volume or the lung tissue is actually fine, but the lung tissue is fine, but they have reduced lung volumes. And that tends to be an issue with either the phrenic nerve or the diaphragm. And like I said, it's pretty unique to lupus. It can lead to death. So lupus also affects the heart, as you would expect. Cardiac disease is common in SLE patients and can often involve all the layers of the heart, the pericardium, myocardium, the valves, and the conduction system, and the blood vessels. Pericarditis tends to be the most common, with or without effusion, tends to be the most common manifestation of lupus. Again, that's inflammation around the heart. The lining of the heart tends to be inflamed, and that can cause chest pain. Raynaud phenomenon, I touched on earlier. This, can be a skin manifestation, but at the bottom of it, it's a vascular process that oftentimes cold stress, flare up can induce spasm of those small blood vessels, and it's a pretty common feature. About half lupus patients will have Raynaud phenomenon. And like I said, you kind of have to ask for that because most patients with Raynaud's phenomenon, they've had it for a while and they just kind of get used to it. So that's usually a clue that something else is going on. They could also have vasculitis. Vasculitis is a serious rheumatological condition. Lupus patients can have that. Not very common, but about 11 to 36% of patients will have either small vessel vasculitis, or it can also be medium or large vessel vasculitis. Usually it will manifest as skin lesions, but don't discount that the vasculitis you're seeing might be due to lupus. And then lupus also has, as you would expect, neurological manifestation. It can affect the central nervous system. It can affect the peripheral nervous system. The central nervous system features such as, and the list is longer, but these are just some of the common features you see: brain fog, seizures, CNS vasculitis, movement disorders like choreiform disorders. In the peripheral nervous system, it could cause Guillain-Barré-like syndrome, autonomic neuropathy, myasthenia gravis, and mononeuropathy. So the spectrum is broad. Now, I want to talk about CNS vasculitis for a little bit because this can be quite serious. It typically presents with fevers, seizures, meningitis, and altered mental um, um, patterns of behavior. If you see a young patient with altered mental status and really the CT scan is good, the MRI is good, angiography is good, you kind of want to check for CNS vasculitis because it's pretty hard to pin down. But spinal fluid is the gold standard for diagnosis. so you kind of want to look to that. But not every patient is going to have altered mental status, so you need to have a high index of suspicion for CNS vasculitis. Um, Lupus can also affect the eyes. It can affect any layer of the eye or every structure in the eye. You know, in the eye, within the eyeball, the eye socket, there's a lot of structures there. And any one of them or any combination of them could be inflamed. And lupus could do that. But most commonly, it tends to cause dry eyes, which is we call keratoconjunctivitis sicca. And we say they have Sjogren's, secondary Sjogren's. Sjogren's syndrome is also a condition on its own, which you're probably aware of, which is characterized by dry eyes and dry mouth. But lupus patients tend to have dry eyes commonly. Like I said, it can affect any structure in the eye. It can include optic neuropathy, choroidopathy, episcleritis, scleritis, and anterior uveitis. Even though those are less common, it can still happen. Now, hematological manifestation, blood manifestation is very common in lupus. In fact, personally, whenever I don't see a hematological manifestation, I'm suspicious of the diagnosis because most patients tend to have, at some point, at least in their life, some hematological issue. All three cell lines, the platelets, the white blood cells, the red blood cells, they can all be affected. Anemia of chronic disease is something you'll find in most lupus patients. Leukopenia, something that is you should look out for. And leukopenia could be due to the prevalence is high. It could be due to lymphopenia, which is also common. That is the lymphocytes are reduced in number, or neutropenia, where the neutrophils are reduced in number. But that will show up on your CBC as reduced white blood cell count. Lupus patients also commonly have mild thrombocytopenia, slightly reduced platelet count. Usually it's not consequential, but every now and then patients can have also ITP, wherein they would need a regular treatment for that. Autoimmune hemolytic anemia is another rare manifestation of lupus. This is where antibodies are attacking the blood cells, particularly the red blood cells. This could be rapidly life-threatening and requires treatment with steroids. So, you see a patient who's just going, one day you see them at hemoglobin of 10, and the next day they're at hemoglobin of 7. You kind of want to act quickly. With no evidence of bleeding, you kind of want to act quickly. The lymph node enlargement, very common. Patient comes in with lymph node enlargement, fever. It can look like an infection, but it might just be lupus. And typically the cervical, axillary, inguinal lymph nodes will be enlarged, usually in the head and neck most of the time. So on to the next slide. So antiphospholipid syndrome, I kind of touched on this earlier. This syndrome is an entity on its own, but up to 30% of lupus patients will also have antiphospholipid syndrome, and that it requires its own blood testing as well. But we won't go into all that today. I'll just say that antiphospholipid syndrome tends to the hallmark is hypercoagulability. They tend to have recurrent thrombosis on either the arterial side or the venous side. So that's a key feature of APS. Thrombocytopenia, again, is common. These patients, one of the screening questions I ask is, have you had any miscarriages? How many miscarriages have you had? Because that tends to be common due to the clotting, the frequent clotting of the placenta. The mothers tend to lose their babies. Usually, there's a formal diagnostic criteria, and it's miscarriages, more than one miscarriage after the second trimester is a main criteria. But if it was in the first trimester, it needs to be 3 miscarriages. If you diagnose a patient with this, they need to be on lifelong anticoagulation. Warfarin has been, in all the studies, the superior anticoagulant used. Sometimes, no one likes warfarin, but sometimes we try to use the other anticoagulants like the DOACs, but Warfarin, I think, has been shown to be superior to those. I mentioned earlier, this can be a primary condition without lupus, or it could be secondary to lupus itself. Now, GI manifestations also happen in lupus, not all the time, but it's there. Up to 25 to 40% of patients with SLE will have some GI involvement. It could be either due to the disease itself or some of the medications we're given. Most times it's the medication we're given. So things you'll find would be dyspepsia or GERD, gastritis, peptic ulcers. They're usually present most times because of reaction or response to because of the medication we're given. Sometimes lupus patients will have abdominal pain, nausea, and vomiting. You do all the workup and nothing comes up. And that could just be the lupus. Up to 30% of patients will have this. And then again, another entity, autoimmune hepatitis, can be a feature of lupus. It can also be an entity on its own, wherein that's all the patient has. But that's something to watch out for. Elevated liver enzymes, no clear cause. Patient has lupus, they might be related. It responds well to the immunosuppressive regimen. Now, the kidneys, the renal manifestation, this is quite has a high prevalence in lupus, and this is what we fear as practitioners because this could go bad real fast. So kidney involvement is like I said, is up to 50% of lupus patients will have some form of kidney involvement or another. The clinical presentation is highly variable of lupus nephritis. It could be just proteinuria to nephrotic syndrome to rapidly progressive glomerulonephritis. Anything can happen. So you kind of have to be, this is what we try to guard against, really. And up to 10% of patients with lupus nephritis will go on to have end-stage renal disease and need dialysis. So I'm not going to go through all of this. This is a lot of words, but this is showing you the different classes of lupus nephritis. Lupus nephritis is not one thing. It's many things. But there's a classification system and they kind of mean different things. So all I will say here is that class 3 and 4 are the most serious because they are active inflammation in the kidneys and it needs to be stopped yesterday. So those require immediate treatment. Class 6 is the kidney is too far gone. It's damaged, it's sclerosed, fibrosis, hopefully they still have some renal function left and they can manage, but it's treatment is not useful here. Class 5 is kind of in between, and 1 and 2 are kind of they're not super consequential. And one of the things about the classification system of lupus nephritis is when you see the class 1 to 6, they're not sequential. It's not a patient doesn't go from 1, 2 to 3 to 4 and so forth. No, it's just kind of, again, different snapshots of what's going on in the kidneys. But 3 and 4 require treatment. They need to see a nephrologist and rheumatologist, most times both. Now, these are some of the features you can find in lupus nephritis and their prevalence. So proteinuria, as you can see, 100%. Patients with lupus nephritis almost have 100% proteinuria, or have proteinuria 100% of the time. And this is actually the way we screen for lupus nephritis. You do a urinalysis and look for the urine protein creatinine ratio, look at how much protein they're spilling. They can have, nephrotic proteinuria syndrome, which is vast amounts of protein in the urine. That's about 45 to 65% of the time. Most times they have microhematuria, blood in the urine, not very visible, but microscopically. They can have red blood cell cast, and they can also have hypertension as a result of failing kidneys and tubular abnormalities. So these are a patient can have 1 or 2 of these or combination of these. Now, there are some disparities in lupus nephritis, which we've seen. Most of the studies show us that African American patients and Hispanic tend to suffer more when they have lupus nephritis. They tend to have lupus nephritis more And when they do have lupus nephritis, it tends to be more severe compared to their uh, Caucasian counterparts. Why is that? The same reasons as others. It could be other factors such as socioeconomic status, poor compliance with medication, the presence of other disease in addition to lupus can worsen it. But there's also some suggestion that African Americans respond to treatment differently. Studies have shown that mycophenolate, MMF, here tends to be um, better tolerated and more efficacious for African American patients compared to the more toxic cyclophosphamide. Um, so there are big differences in lupus nephritis. And like I said, this is the complication that we all fear, we want to avoid. You want to normalize try to get their serum creatinine to normal as fast as you can and reduce the proteinuria as fast as you can. If you can't achieve this within 6 months of starting therapy, it's not looking very good for the patient. It really doesn't. So some of the lab testing you should order when you're seeing a patient or you think you're seeing a patient with lupus, the basic stuff, TBC, CMP, urinalysis for sure because of that proteinuria we had mentioned, muscle enzymes, the CRP and SED rate, even though those could be unreliable sometimes, but they add to the data point. You want to get a chest X-ray, the ANA, of course, EKG, and depending on your suspicion, you can see the complement and anti-double-stranded DNA. Well, these are helpful. So there's always, if you suspect the patient has lupus, you want to order anti-double-stranded DNA and the complements, C3 and C4. Now, these are some more in-depth or more specific autoantibodies that we order as rheumatologists, and they kind of tell a different story. So I'm just going to point out a few, not all of them. Double-stranded DNA is highly diagnostic for SLE, particularly lupus nephritis. This we order regularly because it correlates with flares of the disease. So when it's up, the patient is likely having a flare. When it's down, likely not. Specifically lupus nephritis. So this is very useful, double-stranded DNA. And it's quick. The turnaround time for it in most places is pretty quick. And then SMIT antibody. This, again, we order as rheumatologists. If this is present, the patient more than likely has lupus. There's a lot of false positive ANAs and, sometimes even false positive double-stranded DNAs. But when I see anti-SMIT antibody present, this patient has lupus for me. U1-RMP, we see this with mixed connective tissue disease, lupus overlap. Not so useful. SSA, again, we see this in Sjogren's syndrome and lupus patients as well. It tends to be associated with neonatal lupus, photosensitivity, Sjogren's syndrome, and subacute cutaneous lupus, like I had mentioned, and a condition called NMO spectrum disorder. So those, I think, are the clinically useful ones, SSA, double-stranded DNA, and SMIT. The rest are not so useful. We don't order it as much. So I wanted to touch on pregnancy in lupus because it matters, Only 67% of pregnancies in lupus patients are successful, as opposed to 85% in the general population. Now, that's a big difference. There's several contraindications to pregnancy where the life of the mother is jeopardized. So if the patient has myocarditis, renal failure, malignant hypertension, pulmonary hypertension, or recurrent thromboembolic events, it's not wise to proceed with pregnancy. You kind of want to steer the patient clear of that, at least till these things are resolved or controlled. Some of the medications we use are contraindicated. They're not good for the fetus. Methotrexate, cyclophosphamide, mycophenolate, cyclosporin. We don't use that as much anymore, but you don't want to give that to a patient who you anticipate is going to be pregnant. ACE inhibitors, warfarin and rituximab. Most pregnancy flares occur during the first trimester. Prevalence of preeclampsia is higher in patients with SLE. So, oftentimes patients with lupus or patients who've had active lupus tend to see OBGYN specialists such as MFM, maternal fetal, high risk obstetric and gynecologist. Um, Usually steroids are permissible during pregnancy, so you could give that. And hydroxychloroquine, the other drug we give, is also permissible during pregnancy. So what's prognosis like? The overall 10-year survival is 85 to 90%. Not too bad. Um, However, mortality is increased 3 times compared to a healthy age-matched population. So um, that is not nothing. That lupus can affect the lifespan. Common causes of death include infection. Up to 25% of death are usually medication related. Immunosuppressives increase the risk of infection. Active lupus, such as CNS vasculitis, CNS lupus, lupus nephritis, pneumonitis, myositis, myopericarditis, all these can lead to deaths. Um, Lupus patients, like most autoimmune patients, tend to have higher cardiovascular disease burden compared to the regular or normal population. Oh, sorry, what was that? Okay. And then malignancy. HPV-related malignancies are increased in lupus patients. Um, Sometimes some of the drugs we give as well can also slightly increase their risk of malignancy as well. So these are the common causes of death: infection, active lupus, heart disease, and cancer. And that's it. Thank you. I hope I didn't go over the time.
Thank you, Dr. Mbonu. Do we have any questions from the audience?
I have a question, Dr. Mbonu. So, what
Yeah.
is the prevalence of patients with lupus that develop strokes?
Strokes. I don't know the exact number, but they are certainly at an increased risk for stroke. That goes with a cardiovascular disease. Like I mentioned, um, patients with lupus and other autoimmune disease, inflammatory autoimmune disease, they tend to have cardiovascular, um, worse cardiovascular outcome at a higher rate. Um, I don't know the exact number for stroke. I don't have it with me, but it's certainly higher than an age match patient without lupus.
Thank you.
Dr. Supre, I think I saw your hand. Did you have a question as well?
Yeah, I did. So I used to work in the emergency department, and of course, saw quite a few patients that have lupus. I guess one of my main questions would be, I know that there are so many complications related to lupus. What are some
Mhm.
of like the top two or three that someone in the emergency department should really be looking out for? I know pregnant population is a little different, but I guess across all populations, what are those top diagnoses that we should really be looking out for someone coming in to the emergency department?
Infection. Infection is pretty high up there because if the patient has already been diagnosed with lupus, they're on treatment. Depending on the treatment, infection tends to be high. Um, Pneumonias, skin infections. Um, Females tend to get a lot of UTIs. So infection is a common complication of lupus and lupus treatment. Depending on the treatment, depending on the treatment, you can have different sort of complications. So I'm thinking something like cyclophosphamide. If the patient was treated with cyclophosphamide, um, that can cause infertility, amongst other things. We don't use that drug as much anymore, but I don't think that's not a condition you'll be seeing in an emergency room. Lupus nephritis is something every provider should have like the antennas up for. You see a patient with lupus or a history of lupus and their creatinine is going up, that is concerning. That's pretty concerning because it might be lupus nephritis and they could quite easily, lose the function of their kidneys. Um, Blindness from lupus eye disease. That's not very common. So I don't, it's not really very common, but it can happen, it can happen. Um, but again, cardiovascular diseases is probably, so I'll say number one is infection. Number two is cardiovascular diseases because they still have heart attacks, they still have strokes. But you might see it in a patient younger than you expect. So like 30-year-old female or 40-year-old female coming in with chest pain. It could be a heart attack. Um, Coming in with you know, weakness on one side, that could be a stroke. But you might not expect because you're used to seeing it in older patients. But with lupus, you might see them younger. So I would say infection and cardiovascular diseases are two big complications of the disease. And then the um, treatment related adverse reactions can vary a lot. Patients who are on prednisone, they can have fractures from being on long-term prednisone. They can have diabetes from being on high doses of prednisone. Um, Generally, patients who are borderline diabetics, prednisone usually tips them into full-blown diabetes. Um, and I'm sure a lot of times, diabetes is picked up in the ED for the first time. Patients coming in with polyuria, polydipsia. I don't know what's going on, and it turns out they have, severe complication of diabetes. So that can happen as well. But if to sum it up quickly, infection and cardiovascular disease.
And oh, thank you for that response. As a follow-up question too, it's not something, of course, I would be doing in the emergency department,
Yeah,
but is so with lupus, is it? I know a lot of the rheumatological conditions can be difficult to diagnose, and would lupus kind of fall into that category as well? Is this something that someone could have for some time and just not really have a true diagnosis? Do you see that often with those
very
that
much.
have systemic
Yes,
lupus?
yes, very much so. Because as I showed, the manifestations can be very vast. And I didn't include a slide of I was going to include a slide of the official criteria for inclusion in studies. And patients can have one or two manifestations and make a diagnosis of lupus, or they can have more than that. But what that means is that two lupus patients can look very differently. And that can make diagnosis hard sometimes because everyone doesn't really fit the same archetype, so to speak. And then you have something like fibromyalgia. That's probably the most common issue, is that there's a lot of patients with fibromyalgia who have positive ANAs but don't have any other feature of lupus or inflammation. And that can lead to a lot of confusion for the patient and for many other doctors. So that happens very commonly, Body pains, very common. Fatigue, very common. Skin rashes are very common. Um, and in the wrong or right circumstance, you could diagnose that patient with lupus and it may not be lupus. So it the short answer is yes, it can be hard to diagnose lupus because of those things. A lot of the lupus features are non-specific.
Thank you.
Thank you for those questions.
Thank you, Dr. Mbonu.
Out of curiosity, has anyone here treated a lupus patient or know of a lupus patient?
I've seen, like I was saying before, I saw them in the emergency department. So I've seen them where we see the creat trending up,
Yeah.
where we're comparing previous numbers. I've seen them, like you said, with infection, of course,
Mhm.
because they're higher risk of that often because of the immunosuppressant medications that they're on as well. So those are two of the things I've seen. I remember seeing a patient few years back who was young, exactly how you described, actually, who was a younger patient with lupus who came in with stroke-like symptoms.
Mm.
And what I'll say is we were already high alert, not even just because of lupus, because she had had a stroke before.
Yeah.
And so that was something that I'd seen before. So a lot of the things that you described I have seen in lupus patients in the emergency department.
Right, right. In my experience, when the disease comes early, young, like the 20s, those patients tend to be hit harder than it tends to be more severe when they get it younger than in old age, by and large.
And it's more common in the younger ages, right? If I
Yes,
remember
yes,
correctly.
it is. Yes, yes. Well, thank you guys. I appreciate being invited on.
Thank you so much. It was a great presentation. We appreciate it.
No problem. Thank you.
All right. Well, thank you very much to both of our wonderful speakers this evening. It really was a excellent night of information and definitely some things to look at a little further as well. So really appreciate everyone's time this evening. And our president, do we have any other information or any other words of wisdom for our group before we say goodnight?
Just really want to appreciate our speakers. We've learned so much from you during your presentations, and we look forward to having you again sometime in the future. We really thank you for your time. You'll be getting a thank you email from us as well. If you have any questions for us, or always reach out, please.
Thank you.
Thank you.
And of course, to our host, Dr. Danuf, thank you for hosting our presentations today, or our webinar today. We really appreciate you.
Thank you for having me. I hope to see everyone tomorrow night.
Thanks, everyone. Have a good night.
Good night,
Good night.
everybody.